Sita Raman. Sita Raman.
Oh, so good evening, sir.
Good evening. ரெண்டு பேர் ஜாயின் பண்ணிட்டாங்க. தங்கராஜ் சாரும் அமைச்சர் சார் ஜாயின் பண்ணிட்டாங்களா?
Sir, no sir, no join பண்றது சார். சார்ட்ட பேசுறேங்க சார்.
பேசுறீங்க.
ஓகே ஓகே.
மீட்டிங்ல தான்ப்பா ஜாயின் இருக்கேன். எனக்கு ஆடியோ மட்டும் வர மாட்டேங்குது. ஹலோ
சார், உங்களுடைய ஆடியோ நல்லா தான் இருக்கு சார்.
கேக்குது
கேக்குதுங்க சார், நல்லா தான் இருக்கு.
ஹலோ
சார் சொல்லுங்க சார். டாக்டர் சரவணன் பேசுறேன் சார். நானு இங்க இருந்து கேக்குது சார்.
ஆடிபிள் தானே?
ஆடிபிள் சார், ஆடிபிள், கிளியர்லி ஆடிபிள்.
ஸ்டார்ட் சார்.
Sir, good morning. Good evening, sir.
Good evening, sir.
Good evening, sir.
Welcome, sir. Welcome, Saravanan, sir, and Tangaraj, sir. Welcome, sir. Nice to be along with you.
Yes, sir. Shall we start, sir?
Yes.
Okay, sir. Okay, sir.
Sita Raman, ready ஆகறீங்களா?
Sita Raman, ready?
Sir, yes sir, ready sir.
Ready.
Slide show மாத்திக்கங்க.
Sir, okay sir.
Yeah. So good evening and welcome you all for this evening. This virtual API-ICP postgraduate training program for this week. We have with us the faculties from Department of Medicine, Dr. Namachivayam sir, Professor of Medicine Unit Chief. With us, really thank you sir for being this faculty for this evening also. And we have with us Professor of Neurology, Senior Consultant Neurologist, Dr. Tangaraj sir. Really thank you sir for being with us for this evening to discuss about the case of cerebellar ataxia. We have with us Dr. Sita Raman, the postgraduate from Department of Medicine, KEPB Trichy, to present this case on the cerebellar ataxia. Over to Dr. Sita Raman and Dr. Tangaraj sir and Namachivayam sir to take over further proceedings of this session. Thank you. Make it slideshow, Tangaraj. Sorry, Sita Raman. Sorry, sir. Sita Raman.
Sir, already open the slides, sir.
ஸ்லைட் ஷோ தம்பி. அந்த மேல லெஃப்ட் சைடுல பாருங்க, கீழே இருக்கும் பாருங்க, ஒரு ஐகான் இருக்கும் பாருங்க ஸ்லைட் ஷோக்கு.
Now sir.
There is an icon. ஒரு 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 கப் மாதிரி இருக்கும். அதை கிளிக் பண்ணுங்க, it will become slide show. இல்லைனாக்க லெஃப்ட் சைடுல மேல டாப்ல பாருங்க.
Yes sir, நான் பண்ணிட்டேன் சார்.
இல்லைங்களா தம்பி? From the beginning. Yeah. இங்க இருக்கு பாரு. சரி, ப்ரொசீட் பண்ணுங்க.
சார், ஸ்லைட்ஸ் வருதுங்களா சார்? ஓபன் பண்ணி.
வருது. யா ஃபர்ஸ்ட் ஸ்லைடு இது போங்க. ஃபர்ஸ்ட் ஸ்லைடு.
ஓகே ஓகே சார். குட் ஈவினிங் சார். So this is Mr. Ritesh, 13 years old male, accompanied by his mother. History collected from his mother, whose relative is fair. He is a resident of Kulithalai, Karur. Presented with the chief complaints of unsteadiness while walking since 3 years of age, and complaints of slurring of speech since 3 years of age. History of presenting illness: patient was apparently normal till 3 years of age with normal developmental milestones. After 3 years, his mother noticed that the child was swaying while walking, which is insidious onset. Initially, he had difficulty while walking fast with the tendency to fall and walking in narrow pathway, then progressed gradually to difficulty in walking on level ground and broad surface, which is not associated with vomiting, tinnitus, vertigo, and ear discharge. Initially, the unsteadiness was progressive and then it remained static. Initially, he need assistance for walking, now improved to a state that is able to walk with both feet wide apart without support. Unsteadiness not aggravated on walking in dim light or while washing face. No history of swaying in sitting posture. History of frequent falls due to unsteadiness, which is not associated with the loss of consciousness, seizure, or syncope. History of clumsiness of hands in the form of difficulty, not able to hold the tumbler while drinking milk or water. History of smearing of food on face. History of slurring of speech since 3.5 years of age.
Mr. Raman, change your slide. The same slide, you have not changed your slide. First slide appear. Change your slide.
Already changed, sir.
இல்லையே இங்க வரலையே. Proper share your screen.
Yes, sir.
Don't be tensed, be cool.
Sir, actually, இதுல change பண்ணிட்டேன் sir.
இல்லை வரலையேப்பா.
இப்போ வருதுங்களா சார்?
ஃபர்ஸ்ட் ஸ்லைட்லயே இருக்குப்பா. தேர்ட் ஸ்லைட்ல இருக்கு.
என்னாச்சுப்பா, ஏதாவது பண்ணிட்டீங்களா? அது அப்படியே ஸ்லைடு அப்படியே நிக்குது. ஸ்லைடு மூவ் ஆகவே இல்லையப்பா. இட்ஸ் நாட் மூவிங்.
சார் இப்போ மூவ் ஆகுதுங்களா சார்?
யா, இப்ப பெட்டர்.
சார் ஓகே சார்.
ஸ்லைட்ஸ்ல போங்க. ஸ்லைட்ஸ் டிஸ்ப்ளே ஆகல. யா, இப்ப வந்து ஸ்லைட் ஷோ பண்ணுங்க. கரெக்ட்.
Sorry for the inconvenience.
நோ இஷ்யூஸ்.
Sir, history of presenting illness. Patient was apparently normal till 3 years of age with normal developmental milestones. After 3 years, his mother noticed that the child was failing while walking, which is 60 days onset. Initially, he had difficulty while walking fast with a tendency to fall on the narrow pathway, then progressed gradually to difficulty in walking on level ground and broad surface, which is not associated with vomiting, tinnitus, vertigo, and ear discharge. Initially, he had assistance for walking, now improved to a state that he is able to walk with both feet wide apart without support. History of unsteadiness not aggravated on walking in dim light or while washing face. No history of swaying in sitting posture. History of frequent falls due to unsteadiness, which is not associated with the loss of consciousness, seizure, and syncope. History of clumsiness of hands in the form of difficulty in not able to hold the tumbler while drinking milk and water. History of smearing of food on face present. History of slurring of speech since 3.5 years of age. His pronunciation was unclear. There is multiple pauses in between the words. However, he had no difficulty in understanding the spoken words, repeating the words, or naming the objects. No history of explosive quality of voice. History of poor scholastic performance. History of convergent squint in right eye. He able to comb back, carry foot to mouth, use the hand for toilet purposes, able to buttoning and unbuttoning shirt, but it is slow compared to normal individual, able to get up from squatting position, able to climb stairs up and down, able to hold slippers, there is no slippage of slippers noted, able to roll over the bed or getting up from bed, able to raise the head from pillow in supine position, able to hold the head in upright posture while sitting, no issue of difficulty in breathing or swallowing, no issue of abnormal posture, no issue of stiffness, blindness, wasting or twitching, no issue of muscle cramps, no issue of postural instability or slowness of movements, no issue of thinning of muscles. He able to feel his clothes, able to feel insect bites, able to feel hot and cold water while bathing, no issue of numbness or pins and needle sensation in limbs or walking on cotton wool feeling, no issue of neck pain or back pain, no issue of band leg sensation, no issue of sharp leg sensation passing over the spine while bending the neck, able to appreciate coffee and tea smells, uh, able to see distant and near objects. He has no difficulty in identifying the colors, able to move his eye in up and down or side to side position, not associated with pain, no issue of double vision or adapted head tilt, no issue of drooping of eyelids, able to chew the food, able to perceive facial sensations, no issue, uh, so, no issue of bladder and bowel disturbances, no issue of abnormal sweating or dryness of skins, no issue of postural giddiness, no issue of memory loss. Uh, Sir, actually, some history was missing. Sorry, sir. So, no other craniosity are able to hear properly. No issue of difficulty in swallowing. No issue of difficulty in turning head side to side. No issue of difficulty in shrugging the shoulder. No issue of bladder bowel disturbances. No issue of abnormal sweating, dryness of skins or hair loss. No issue of postural giddiness. No issue of memory disturbances. No issue of loss of consciousness. No issue of behavior and emotional disturbances. No issue of sleep disturbances. No issue of delusion or hallucination. No issue of seizure. No issue of history of failure to thrive. No issue of constipation or taturia. No issue of recurrent sinusitis. No issue of ear discharge. No issue of spinal deformity. Past history, not a known case of diabetes mellitus, systemic hypertension, tuberculosis, hypothyroidism, or seizure disorder. History of bilateral elbow fracture because of fall for which he was operated. Patient was diagnosed as nephrotic syndrome, minimal change disease in biopsy at 3 years of age, and he was on steroids. Birth history, firstborn of non-consanguineous marriage, LSA's delivery due to low amniotic fluid index, cried immediately after birth, exclusive breast milk was given up to 6 months of age. Developmental history, neck holding attains at 5 months, stands without support at 1 year. A patient runs at 18 months, jumps at 3 years. This is the pedigree chart, sir. Uh, uh, According to history, this patient only affected, sir. No other, his parents and grandparents were not affected. Sir. Summary, a 14 years old, known case of nephrotic syndrome, admitted with a chronic neurological illness, insidious onset, initially progressive, and remains static in the form of unsteadiness while walking, slurring of speech, tremulousness while reaching for objects, with a normal motor, sensory, bladder, bowel, and autonomic function, normal cranial loss, and normal higher mental function, with no positive family history. Sir. Sir. Hello, sir.
So, what are the, what is it and where is it and how is it? Is it a neurological disorder?
Yes, sir.
Subramurthy?
Sir,
Audible?
sir. Audible, sir.
Audible, okay. So, which part of the nervous system affected from your history?
From my history, because of unsteadiness while walking, slurring of speech, the structure involved is cerebellum, sir.
Okay. Cerebellum, which part of the cerebellum is affected here?
Sir, here there is unsteadiness of gait, sir. Unsteadiness while walking, sir. So this may be due to the unsteadiness is due to incoordination of lower limbs, sir.
That is gait ataxia. That is gait ataxia. Okay. Then what other cerebral symptoms he is having?
Slurring of speech, sir.
Gait ataxia, limb
Slurring
ataxia,
of
and dysarthria.
Yes, sir.
He has how the symptoms started? Almost all the symptoms are 3 years.
Sir, first initially unsteadiness was started. Sir, first unsteadiness was started.
From your history, even
Sir.
speech disturbance little start early, la? 3.5
Sir,
years or something you put there.
Yes, sir.
Huh?
Yes, sir.
That smearing of food along, what time it started? Or all the symptoms started simultaneously?
Sir, initially unsteadiness was started, sir.
Then how many months later patient developed upper limb ataxia?
So over a period of 3 months, he developed a upper limb ataxia, sir, incoordination of upper limbs and tremors, sir.
See, you have to very careful in asking the history. So whether the ataxia started in the lower limb, then it involved the trunk, upper limb, and speech, or it started simultaneously, gait ataxia, limb ataxia, dysarthria, everything simultaneously and slowly progressive.
Sir, initially started in lower limb, sir, and then progressed to involve upper limb and dysarthria, sir.
How many months later?
Sir, around 6 months, sir.
What age started? 3 years of age, yeah?
Yes, sir.
Up to the 3 years, totally normal.
Yes, sir, he was normal, sir.
So after that, patient developed gait ataxia first, or everything slowly, whether a gait ataxia, limb ataxia, dysarthria, everything slowly, all simultaneously.
Sir, involved slowly, sir. Initially gait ataxia, followed by limb ataxia, sir.
Followed by now, how many year gap?
Sir, within 6 months duration, sir.
So 6 months, not much thing.
Okay, sir.
Now almost he has pan-cerebellar features, yeah?
Sir.
He has gait ataxia, limb ataxia, dysarthria, everything he is having.
Yes, sir.
Huh?
Yes, sir.
Is it any asymmetricity between the right side and the left side?
No, sir, it is symmetrical, sir.
It is symmetrical. Okay. No positive family history.
No
Okay.
past history. Yes,
Huh?
sir.
Oh,
Sir.
no positive family history.
Yes,
So
sir.
what would be the possibilities?
Sir, it may be of congenital cerebral ataxia, sir. Sorry, degenerative ataxia due to hereditary causes, sir.
Is it a progressive ataxia, non-progressive ataxia?
Sir, non-progressive, sir.
Hmm?
Initially
You
progressive.
said initially gait, then limb ataxia, everything, and now it is almost disturb his activities.
Yes, sir.
Whether he is able to walk without support.
Yes, sir. He is walking without support.
Frequently, he is fell down.
Yes, sir.
Hmm?
Sir, now he is walking without support, sir, but with a weight-based gait, sir.
But whether he need help for activities of daily living.
No, sir.
Hmm?
No, sir. No, sir.
Hmm.
Now he is walking independently, sir.
So, what would be the possibilities?
Sir, actually, this is the ataxia.
He has involvement. Which part of the cerebellum is affected now? Midline cerebellum.
Yes, sir.
Midline cerebellum, spinocerebellum, or cerebellar hemisphere, or everything is affected.
Sir, since speech is affected, there is the involvement of posterior left hemisphere involvement is there, sir.
I will ask you one question.
Yes,
What are the features of midline cerebellum involvement? Midline cerebellum means vermis.
Vermis, sir.
Anterosuperior vermis.
Yes, sir. And then, sir, if the vermis is involved, there is gait ataxia.
So, midline cerebellum predominantly produce gait ataxia. Okay, abnormal head posture, truncal
sir.
ataxia,
Yes, sir. Yes, sir. Intubation
some
will be
amount of ocular motor abnormalities. Okay. What abnormalities of the cerebellar hemisphere it will produce? What we call it as appendicular ataxia. Yeah. So that will be produce hypotonia, intention tremor, dysmetria, dysarthria, dysdiadochokinesia, everything. Okay. Now this patient having gait ataxia, limb ataxia, dysarthria, bilateral, symmetrical from the age of 3. So only important question is it is progressive or non-progressive or slowly progressive.
Sir, initially slowly progressive and then remains static, sir.
Now it is static. Okay.
Yes.
So up to the age of 3 years, normal.
Yes, sir.
Then how can you call it as congenital ataxia? So congenital ataxia, whether it is inherited ataxia,
yes, sir.
or some due to some other thing. So simply we call it as early onset ataxia. It is a case of
Early onset.
so early onset ataxia, we have Friedreich's ataxia, then
Yes,
Friedreich-like ataxia, then early onset ataxia.
yes,
so if it is a Friedreich's, what is Friedreich's-like ataxia and Friedreich's ataxia? What could be the features? It starts from the lower limb. Okay, caudal to rostral. It starts from the lower limb, then upper limb, speech, everything in a sin border. That is caudal to rostral progression. Okay, but here it is not that type of progression. It is a simultaneous involvement of all limb ataxia, dysarthria, gait ataxia. Okay.
yes,
So it is a early onset ataxia. It is not unlikely a Friedreich's ataxia or Friedreich's like ataxia.
yes,
So
sir.
early onset ataxia or means it from the age of 2 to 20 years of age. Previously, before if the ataxia started before 25 years of age, we call it as early onset ataxia. Generally, they will start from the age of 2 to 20 years. Okay.
Yes, sir.
So it is the way by which the onset of symptoms and things,
Yes, sir.
it is a slowly progressive or non-progressive. So it is unlikely Friedreich's ataxia, okay,
Yes, sir.
or Friedreich's like ataxia. So what could be the group of ataxia which starts very early and behave like this? There is no positive family history in this case.
Yes, sir.
There is no positive family history. Whether it could be any, sorry, okay, ataxia, bilateral, symmetrical, chronic, what could be the etiological? Only degenerative ataxia, like inherited ataxia, or a metabolic disorder can produce a simultaneous, okay, metabolic disorder.
So, hypothyroidism causes chronic symmetrical attacks.
Hypothyroidism, it's if not treated, it will progress. Any features of hypothyroidism in this case?
No, sir.
No. Only thing is a known case of some renal abnormality.
Yes, sir.
As from your history, he is suffering from the proteinuria.
Yes, sir.
Okay. Sorry. Okay. Any other autoimmune disorder can affecting the kidney, cerebellum, or anything like this? Or any congenital disorder, sir?
Sir,
the nephrotic syndrome secondary to any other problem, it produces this ataxia.
Sir, actually, in Galloway-Mowat syndrome, there is associated nephrotic syndrome with the cerebellar ataxia features. Sir.
What?
Sir, Galloway-Mowat syndrome, sir. Sir, but there is microcephaly is present, sir. In this case, there is no microcephaly, sir. Hypotonia is predominantly seen there, sir. with the developmental delay, and seizure also will be there, sir.
But here there is no developmental delay,
Yes, sir.
no mental retardation.
No mental retardation, sir.
Hmm. So it will be fit into the early onset ataxia associated with some metabolic disorder, inborn errors of metabolism, okay,
Yes, sir. Yes, sir.
leukodystrophy, or
Yes, sir.
we have to search for it later, investigate, okay.
Yes, sir.
So it is unlikely Friedrichs or Friedrichs like ataxia.
Yes, sir.
So early on, Friedrichs ataxia is the most common. Okay, now there is no family history here. Okay.
Yes, sir. No. Yes, sir.
Suppose a patient with ataxia, no family history means still it could be a possibility of inherited ataxia.
Yes, sir. Because of autosomal recessive, there will be
Previous
transmission from
generation, the ataxia
Yes,
may
sir.
be subtle.
Yes, sir.
Next generation, it will
Yes, sir.
start early, what we call it as phenomena of anticipation. This
Yes,
is
sir. And
the rule for autosomal dominant ataxia.
yes, sir.
Okay.
Yes,
Or
sir.
if the family is very small, only member in the family, you cannot rule out autosomal recessive ataxia.
Okay, sir.
Okay.
Yes, sir.
Sometimes some of the patient, no family history, the biological father or mother may be different. Okay.
Okay, sir.
Biological father may be different.
Okay, sir.
Still, it could be a possibilities of inherited ataxia. Or
Okay,
it
sir.
could be a non-progressive congenital ataxia, like hypoplasia of the cerebellum. Okay. But here,
Yes, sir.
only cerebellum is affected, no other feature
Yes, sir.
apart from renal dysfunction. Okay. So we have
Sitaram.
Sir.
சொல்லு சார் கேக்குறாங்க பாரு.
Sir, yes, sir, there is no significant family history. Only cerebellum features are present, sir. No sensory disturbances, no pyramidal and extrapyramidal involvement is there, sir.
So here only it's a pure cerebellar ataxia, yeah.
Yes, sir.
Which cerebellar and pure cerebellar ataxia, spinocerebellar ataxia manifests pure cerebellar features.
Sir, spinocerebellar ataxia 5.
6 or 7 or?
7% with the visual disturbances, sir.
Oh, 7, 6 I think, pure cerebellum. Okay.
5 and
So we so we will go for further exam. Sir, Namaskar, sir.
சரி சீதாராமன் started by 3 years of age.
yes, sir.
Do you think that the infection that could have precipitated?
Sir, yes, sir.
What infection?
Sir, actually, Lyme's disease will cause treatable cause of ataxia, sir.
Then, if it's due to infection, they can you can see a lot of pediatric cases. They present as acute cerebellitis. They are viral etiology. They could be cerebellitis. Can it be? Did you mention about drug-induced disease? What are the drug-induced hyperkinetic disorders of the CNS? Did you ask for any history of drug intake?
Sir, I asked drug intake, so there is no any.
What drug intake?
Apart from steroids, there is no drug intake, sir.
What drugs you like to ask?
Sir, phenytoin, sir.
Phenytoin, carbamazepine, tricyclic antidepressant, risperidone.
Yes, sir.
So all these drugs you have to ask.
Yes, sir.
Was there any intake of such drug?
No intake, sir. No such intake of these. No, sir.
No. Did the mother suffer from any disease?
Sir, no, sir. Her mother.
Did you ask for any disease which the mother suffers from?
No, sir. She is.
What infection you like to ask?
Sir, for his
what
mother.
What happens when the mother takes diazepam? What disease you likely to get in a child? You should know everything. It is not for the cerebellar, you should know everything as a physician. The mother takes diazepam, what disease the child can be born with?
Sir, actually, this is a teratogenic, sir. Diazepam is teratogenic.
What I don't give the lengthy explanation. Tell me what will you get when the mother takes diazepam?
Sir, floppy infant syndrome, sir.
Floppy baby syndrome or Wernicke-Hoffmann disease.
Yes, sir.
Wernicke
Baby.
is a type of SMA, spinal muscular atrophy. What will happen when she takes sodium valproate? What happens when she takes sodium valproate? The children will be born with
Sir,
neural tube defect.
neural tube defect, spina bifida will be there, sir. And then congenital heart diseases. Sir.
We are talking about neurology, not cardiology now.
Sir,
Don't mess up. Don't make
okay.
things. Okay.
Yes,
What
sir.
will happen when what happens when a mother takes phenytoin? Did you ask for all this? You didn't.
Sir, actually, his mother is not taken any drugs.
Don't. You ask for it. Did this come to your mind?
Sir,
You
yes,
didn't
sir.
ask.
So I asked about mother, sir. Her antenatal.
Specifically, you should ask for all this. Phenytoin, what does it produce?
Sir, fetal hydantoin syndrome.
What is it?
So there will be a cleft palate, cleft lip, hypertelorism will be there, sir. Developmental delay in microcephaly also present, sir.
What are the other diseases you will see? What are the other disease complex you get in patient with if it takes phenytoin for a long time?
Sir, there will be sir, I can't get the question, sir. Sorry, sir.
The cognitive.
Yes, sir.
What disease the person can land when he takes phenytoin for a long time?
Sir, osteoporosis, vitamin B12
Osteoporosis. Okay, then.
Vitamin B12 deficiency.
First gingival hyperplasia, cognitive defect, hyperkinetic syndrome.
Yes, sir.
Hyperkinetic syndrome, wherein hirsutism, Steven Johnson syndrome.
Yes, sir.
Stress syndrome.
Cerebral ataxia also
hyperkinetic syndrome, hyperkinetic syndrome, stress syndrome.
Yes, sir. Megaloblastic
anemia. Pseudo lymphoma-like syndrome.
Okay,
all
sir.
this you should know.
Okay, sir.
So don't stick on to cerebellum alone. You should have asked the mother whether the mother has taken all this and whether she had any infections. What infection? What is Starch's infection?
Sir, sorry, sir.
What is Starch's infection?
Sir,
tell me. T stands for what? Huh?
Sir, torch, sir.
Torches. Torch.
Sir, toxoplasmosis. Sir, rubella, cytomegalo virus. Herpes simplex.
Did you ask for all that? The mother?
Sir, yes, sir. Her mother is uneven.
Don't be hesitant. If you have asked, you should be very dogmatic. Be hesitant. And it means that you have not asked for all this. And plain now, you thought of cerebellum. Clear?
Yes, sir.
Yes, sir. Yes, sir. No, sir. Sorry, proceed.
The general examination is moderately built and nourished. No failure, no icterus, no sinuses, no clubbing, no pedal edema, no lymphadenopathy, no telangiectasia, no hypopigmented hair, no KF ring, no thyroid swelling, no scoliosis, no pes cavus, no dry skin, no ichthyosis, no evidence of neurocutaneous markers, no markers of TB, no markers of HIV, no markers of syphilis, no peripheral nerve thickening, Vitals pulse rate 86 per minute, regular rhythm, normal volume, and normal character, felt in all peripheral pulses. No radio radial or radio femoral delay, no vessel thickening. Corrective diaphragm, no doing. BP was 120 millimeter, 120 by 80 millimeter of mercury measured in right upper arm. Respiratory rate 16 per minute, regular rhythm, and thoraco-abdominal type of respiration. Saturation was 98% room air, temperature 98.6 degree Fahrenheit. Anthropometry, height 145 centimeter, weight 46 kilograms. His BMI was 21.9. Neck length 10 centimeter, height neck ratio 14.1:1. Head circumference 53 centimeter. Higher mental functions, conscious, cooperative, is right-handed individual, oriented to time, place, and person. Memory, immediate result and remote memory were intact. Mood and emotion was normal, no emotional lability. Concentration and calculation was normal, sleep cycle normal. Language, fluency, repetitions, and naming of the objects were normal. Speech disorder present, reading is impaired, and writing is impaired. No apraxia or heavy neglect. MMSC score 23, sir. Cranial examination, olfactory nerve able to perceive smell on both sides. Optic nerve, he's having a normal visual acuity of 6/6. Field of vision is normal. Color vision is normal. Fundus examination shows no optic atrophy or retinal pigmentation, features of retinal pigmentation. It was normal on fundus examination. Third, 346 cranial nerves, no ptosis, extraocular movements full. Prosit was smooth and full. Saccades and bilaterally hypermetric saccades is present. Nystagmus, bilateral horizontal gaze about nystagmus present. Pupils 3 millimeter on both sides around. Both direct and indirect light reflexes present. Accommodation reflex present. Convergence squint present in right eye. Trigeminal nerve, muscles of mastication normal. Sensation on face was normal. Corneal and conjunctival reflexes normal. Jaw absent. Facial nerve, wrinkling of forehead present on both sides. Tight closure of eyelids, eyes normal. Blowing of cheek present. Nasolabial fold present. Deviation of angle, there is no deviation of angle of mouth. Platysma contraction present. Sensory component of the facial nerve. Taste sensation was normal on both sides. On anterior to that of the tongue, lacrimation was normal. Vestibulocochlear nerve, air conduction is better than bone conduction in unit tests in both ear. In Weber test, there is no lateralization. Glossopharyngeal nerve, uvula is in midline. Symmetry of the palatal arch and its movement was normal. Gag reflex normal. Taste in the posterior 1/3 of the tongue was normal. Spinal accessory nerve, shrugging of shoulder and turning side to side was normal. Sir. Hypoglossal nerve, there is no apparent wasting or fibrillations. Protrusion of tongue, he is able to press against the buccal aspect of the cheek. His movement of tongue was normal on side to side. Motor examination. Inspection, there is no muscle wasting. Arm 20 centimeter on both sides, measure 10 centimeter above the medial epicondyle. Forearm was 16.5 centimeter. Thighs 37 centimeters on both sides, leg 20 centimeters. Tone, there is no hypotonia noted. So, tone is normal on both sides. And elbow, wrist, hip, and knee was normal. Power, neck flexion was 5/5, neck extension 5/5 on both sides. Shoulder flexion, extension, adduction, and abduction was normal on both sides. Elbow flexion and extension was normal. Wrist, palmar flexion and dorsiflexion was normal. Thumb flexion, abduction, and opposition was normal on both sides. Finger flexion and extension was normal. Hand grip 100% on both sides. Power on lower limb, hip, flexion, extension, adduction, and abduction was normal, 5/5 powers. Knee, flexion and extension of normal. Ankle joint, dorsiflexion and plantar flexion was normal. Eversion and inversion was good. Toe flexion and extension was normal. Reflexes, superficial reflexes, corneal present on both sides, conjunctival reflex present on both sides, abdominal reflexes present, cremasteric reflex present on both sides, plantar bilateral flexor Deep tendon reflexes. All deep tendon reflexes were 1 plus biceps supinator, triceps, finger flexion, knee and ankles are 1 plus on both sides. Sensory system. Touch, pain and temperature is normal in both sides of the body. Vibration sense was intact. Joint position and motion sense was intact. Cortical sensations, tactile localization was normal, 2-point discrimination normal, stereognosis able to identify the objects in both limbs. Graphesthesia was normal. Cerebellum, coordination, finger nose test impaired on both sides, finger nose test impaired on both sides, dysdiadochokinesia present, heel chin test impaired on both sides. So draw a circle with toe, great toe was impaired on both sides. Rhombus couldn't be elicited since he is not able to stand with feet together. Rhombus couldn't be elicited. Bilateral horizontal gaze evoked nystagmus present. Intentional tremors present in both hands. Scanning speech present. Rebound phenomena present. No titubation. No pendular nature. Gait void based gait. Extrapyramidal system is normal, so no resting tremor, no bradykinesia. No signs of meningeal irritation. Spine and cranium was normal. Other system examination, cardiovascular system, first and second earthzone here, no murmur. Respiratory system, bilateral larynx present, no added sounds. Abdomen soft, no organomegaly, no hepatomegaly or no splenomegaly. Provisional diagnosis. A case of chronic bilateral symmetrical neurological illness in the form of gait ataxia, limb incoordination, dysarthria, the normal higher mental functions, normal cranial nerves, motor, sensory, and autonomic functions with nephrotic syndrome. So I would like to consider possibility of degenerative cerebral ataxia. The probable structures involved were lateral cerebellar hemisphere, posterior left cerebellar hemisphere and awareness, dorsal vermis and floccular lobes.
Any features of nephrotic syndrome? He
Sir,
has anasarca,
no,
pedal
sir.
edema.
No, sir. No, sir. Now he is not having any features of nephrotic syndrome, sir. So in the initial stages, he had frequently admitted for a nephrotic syndrome with multiple relapses.
What
Sir.
symptom made them to evaluate for renal disease?
Sir, initially he had anasarca, sir, bilateral upper and lower swelling with facial puffiness, periorbital puffiness was there, sir. So for that only they initially got admitted in Coimbatore, some private hospitals and evaluated, sir.
Okay. So
And he was
at what age he had symptoms of this?
Sir, after 3 years, sir, nephrotic. Initially, he was diagnosed with nephrotic syndrome.
What age he was diagnosed to have nephrotic syndrome?
Sir, at 3 years of age, sir.
So even the 3 years of age itself, he was found to have nephrotic syndrome.
Sir, yes, sir.
Huh?
Yes, sir.
First symptom is diagnosed as nephrotic syndrome or ataxia.
Sir, first nephrotic syndrome is diagnosed, sir.
That you must be brought in the history. You start with the ataxia, later found diagnosed nephrotic syndrome.
Sir.
So this is very important.
Yes, sir.
So this is very important. Okay.
Okay.
He
Okay,
has some renal disease from childhood.
Yes, sir.
Plus he has ataxia.
Yes, sir.
Okay? So this ataxia. So what are the features against Friedreich's ataxia in this case?
Sir, in this case,
the commonest ataxia, recessive ataxia.
Sir, yes, sir.
Early onset ataxia.
In Friedreich's ataxia, there is dorsal spinal
So
cerebellum.
it is not caudal to rostral progression. It only simultaneously involve all. Okay, that is the first point.
Yes,
then tendon jerks are normal.
Normal, sir.
And no pyramidal involvement, no cardiovascular system involvement. Okay,
no
so
diabetes.
it is not Friedreich's ataxia.
Yes, sir.
Some of the Friedreich's ataxia the tendon jerk may be retained because the severity of Friedreich's ataxia depends upon the trinucleotide expansion. Okay.
Okay, sir.
So when the expansion is less, the manifestation of Friedreich's ataxia less, they may not develop cardiomyopathy, they may not develop diabetes. They may usually the ataxia may not be much severe, but so it can occur even late age also.
Yes, sir.
Previously, Friedreich's ataxia is early onset. So any sporadic ataxia, you have to rule out Friedreich's ataxia.
Yes, sir.
So all these clinical symptoms ruled out itself, even though it is early onset attacks, it rules out the Friedreich's ataxia or Friedreich's like ataxia. Friedreich's like
Yes, sir.
ataxia, what are the things you may get early onset? Vitamin E deficiency, acquired vitamin E deficiency, or congenital vitamin E deficiency, A beta lipoproteinemia. Okay.
Yes, sir.
So these are the closely mimic some all these things which mimic Friedreich's like picture.
Yes, sir.
So that also even vitamin E deficiency reflex will be absent. There will be a neuropathy, ataxia, both can occur. Okay. So it is a early onset ataxia. It must be associated with some in metabolic disorder affecting the renal function as well as cerebellum. Okay.
Yes.
As well as cerebellum.
Cerebellum.
If it is a congenital ataxia, usually there is hypoplasia of the cerebellum in imaging also, but Friedreich's ataxia, cerebellar atrophy may not be prominent. Only congenital ataxia, you can, or other early onset ataxia, it is a more prominent. Okay.
Yes, sir. Yes, sir.
So now we will go for, so we have to evaluate further what are the inborn errors or congenital metabolic disorder affecting the kidney as well as cerebellum. All these things we have to go for. It may
Yes,
be storage disorder like or paroxysmal disorder or any other disease which started congenitally. All these things we have to rule out. Okay.
Yes, sir.
What from the history, some cranial nerve symptoms you said. So what are the things cranial nerve examination in any case of ataxia you have to specifically look for?
Sir, sir, olfactory is involvement is there, sir. In Repson's disease.
So maybe early features of many degenerative disorder. Okay.
Yes, sir.
Then other than optic fundus. Okay.
Yes, sir. Yes,
fundus
sir.
you have to rule out RP, retinitis pigmentosa. You have to look for any papilledema, and you have to look for optic atrophy. Both all these things you have to look for second nerve examination.
Yes, sir.
Which ataxia associated with the optic atrophy?
Sir,
Once again, Friedreich's ataxia, mitochondrial disorder. Okay.
Yes, sir.
This can be associated with the optic atrophy. If there is any CV junction anomaly associated or obstruction to CSF outflow obstruction,
Yes, sir.
since childhood, you have to look for papilledema also. Which ataxia associated with the RP, retinitis pigmentosa?
Sir, vitamin E deficiency ataxia, sir.
Then A beta lipoproteinemia, mitochondrial disorder. Okay. So mitochondrial also affected to produce ataxia, renal dysfunction. Okay. Peripheral neuropathy, everything it will produce. Okay.
Yes, sir.
So it can also produce RP, mitochondrial disorder also.
Yes, sir.
Type 7 ataxia, spinocerebellar ataxia with RP.
Sir, sir. Visual loss, macular degeneration, retinitis pigmentosa will be there, sir.
A beta lipoproteinemia, all these things. Okay. During 3/4 examination,
yes, sir.
Okay.
Yes, sir.
What are the telangiectasia? So bulbar conjunctiva, what will you say, look for?
And telangiectasia will
Okay, so ataxia, telangiectasia is one of the early onset ataxia. Clear? Ataxia, telangiectasia. If there is a retinal telangiectasia, what could be suspect? Von Hippel-Linde disease. Yeah?
Okay,
It is
sir.
associated with the retinal telangiectasia. Ataxia telangiectasia associated with the bulbar telangiectasia. Okay.
Okay, sir.
So it also this patient prone for recurrent respiratory infection. Okay. Ataxia telangiectasia. What deficiency?
Sir,
Something A deficiency.
IgA deficiency, sir. There may be thymic thymus, small or absent thymus will be there. A recurrent sign of pulmonary infection, sir.
Some
There,
factor, some A division, something. So they
It's
are
right.
prone for infection.
Yes, sir.
Is there any such history here?
No such history, sir. No history of recurrent respiratory tract
What
infection,
type
sir.
of nystagmus, the ocular abnormality he had? Gaze evoked nystagmus.
He is
Okay.
having gaze evoked, sir.
So gaze evoked nystagmus, most of the cerebellar disease, not only cerebellum, it can produce other disease also can produce a gaze evoked. One is slow phase, another one is corrective fast phase, that is gaze. What is
Yes, sir.
pendular nystagmus? Which one is very more specific for cerebellum? Gaze evoked or pendular?
Sir.
So pendular more characteristic of cerebellar nystagmus. Okay.
Okay, sir.
There will be a lateral gaze followed by corrective phase opposite direction. Okay.
Cerebellum and the cerebrum works coordinately in this, sir.
It's at hypermetric second.
Yes, sir.
Not
Yes,
only
sir.
hypermetric. What do you mean by hypermetric second?
Sir, when we rapidly ask him
Amplitude, high amplitude.
Yes, sir.
Not only hypermetric, dysmetric second also. You know
Yes, sir.
what is dysmetria? Like a limb ataxia.
Sir, yes,
Okay.
sir.
Finger nose incoordination. So the
Yes,
eye
sir.
movement also overshoot or undershoot. What we call it as saccadic dysmetria.
Yes, sir.
That also is seen in patient with a
Cerebellar.
cerebellar. Okay.
Yes, sir.
Then some of them will have square wave jerks. What we call it as square wave jerks. So there will be a movement on one side. There will be a pause followed by opposite direction movement. That is called a square wave. These are the eye movement abnormalities you can see in patient with a cerebellar disorder. Okay. Then any perifacial, perioral atrophy in the face, what ataxia it will be seen? Professor CUV used to tell this thing. Actually, MJD, you may get see oral atrophy, a facial atrophy.
Okay, sir.
You can see all these things. Okay.
Yes, sir.
So these are the things. Many patients with ataxia, all these things you got to look for. Okay. So now we have early onset ataxia with renal involvement, no family history. So all we have to evaluate further, like inborn errors of metabolism, metabolic disorder, or a congenital disorder, syndrome which are affecting the renal as well as cerebellum. All these things we have to look for.
Yes, sir.
Okay. Namachoya, sir.
Sir, I'll take care. Sita Raman, you told the person has a renal problem as well as a neurological problem. Leah, what are that should run through your mind?
Sir, one possibility.
So,
Yes, sir.
what is adult polycystic kidney disease? What will be the neurological manifestation? Adult polycystic kidney disease.
Sir, sir, there will be SAH will be there, sir.
CHR. Aneurysm. Aneurysm.
Yes, sir. Yes, sir.
Don't beat around the bush. Sorry, what other disease you think of? Seri, you told it was nephrotic syndrome. Was it steroid responsive or what?
Sir, is steroid responsive, sir.
So what nephrotic syndrome is steroid responsive?
Sir, minimal change disease, sir.
What's the other name for it? Nils disease, diffuse food process disease. So they're all steroid responsive. Okay.
Yes, sir.
So still he's on steroids, huh?
Yes, sir, still he's having steroids, sir. But
what is
sir,
the effect of steroid on this central nervous system?
So there will be steroid psychosis. It causes steroid psychosis.
Or it can produce benign intracranial hypertension. Intracranial hypertension, or it can produce steroid psychosis. Okay.
Steroid psychosis.
One is adult polycystic kidney disease. Upper steroid responsive, you are talking in terms of Nils disease or either minimal change glomerulonephritis. What other disease? What is von Hippel-Lindau's disease?
So in von Hippel-Lindau disease, there will be hepatocellular carcinoma. Sorry, renal carcinoma.
Renal carcinoma, renal cell carcinoma, CKD, along with it, don't keep talking. Renal cell carcinoma, CKD, along with it, the person can have cerebellar hemangioblastoma. Children, you should know all this. Cerebellar hemangioblastoma, retinal hemangioma. It is an inherited disease. Okay. What else? Should know the
adrenal gland. Adrenal gland. Pheochromocyte.
HUSR.
So involves adrenal pancreas. Sir, involves adrenal glands.
Other pheochromocytoma will be the other thing, other manifestation. What other disease?
So pancreatic cyst will be there, sir.
What other diseases you get? A combination of renal and the.
So coenzyme 10 deficiencies.
What is it?
Sir, it involves in the electron transport chains. ATP in coenzyme 10 deficiency, there is decreased ATP production will be there, sir.
So it think of what is nephronophthisis? What is nephronophthisis? It is an inherited renal disease where you will have ciliopathy. Okay. Ciliopathy. Okay. The person again here can have chronic kidney disease. Along with this, the person can have cerebellar symptom. Okay. Adilada, you get Joubert syndrome. Joubert, that is cerebellar degeneration of the
vermin hypoplasia.
Hypoplasia of the vermis. So Joubert syndrome, a combination of ciliopathy, nephronophthisis, along with some cerebellar disease. Otherwise, you get Joubert syndrome. Senior local syndrome. Senior local syndrome.
Meckel-Gruber syndrome.
So, you should know the combination of all these diseases. Siri, you told the person has only dysarthria and nystagmus and all this. Did he have any involuntary movement or anything like that?
Yes, sir.
Any involuntary movement?
No, sir. Involuntary movements are sir.
You told it's a chronic disease, no? Did the person have any muscle cramps, contracture? It's a chronic disease. It started from 3 years of age and it was going on till 13. Now he's 13 years old. 10 years are did he have, you told there is no kyphoscoliosis, no sternal deformity, no pescatus, does this person have any pseudo hypertrophy of calf muscles?
No, sir.
Fractures
Sir, call is fracture. No cramp. Sorry, sir. Cramps are sir.
Did you ask for all this?
Sir, I asked it, sir.
You look
History
for
like
contractions, cramps,
no
contractions.
contractions, no problem.
Huh?
No, sir.
No contractions, no cramps. What diseases you get muscle cramps?
Sir, related to cerebellum, sir.
Cerebellum. In a neurological disease, you get cramps, muscle cramps. Huh?
Sir,
Motor neuron disease,
motor neuron disease.
polyneuropathy, radiculopathies. In all this, you can get muscle. See, common disease are rare. Common diseases.
Okay. Motor neuron disease.
Motor neuron disease, polyneuropathy, radiculoneuropathy. He didn't have any involuntary movements.
No involuntary movements, sir.
Nalla theriyuma? No contractions, no muscle cramps, edume illa. No skeletal malformation.
No, sir.
What is myoclonus mari edu irundha?
Myoclonus edu illing, sir.
Edume illa.
No, sir, illing, sir.
Nalla paathiya? What is myoclonus? Define myoclonus.
Sir, it's a sudden, brief shock-like involuntary movements.
Brief, shock-like
Shock-like movements caused by muscle contractions.
Muscle contract. What are the types?
Sir, positive myoclonus, negative myoclonus.
Can be segmental, can be multi-segmental, or it can be generalized. Yeah, it can be all action myoclonus, then known in a negative myoclonus.
Negative myoclonus.
Yeah. What is hypnagogic myoclonus?
Sir?
Hypnagogic myoclonus.
Sir.
Huh?
Sir.
Solluங்க sir. Yes sir. Yes sir. Solluங்க sir. Sir, what is this? Stammering money. Solluங்க. So it is normal. Hypnagogic myoclonus is normal or abnormal?
Sorry, sir.
Hypnagogic myoclonus is normal or abnormal? Sollu, yes or no? Huh?
Physiological type of myoclonus.
I'm asking you.
Sir, it is normal seen in normal physiology.
Somebody sitting beside you.
Sir, no, sir.
Somebody is prompting. I could hear.
Sir, no, sir. Sir. Room.
I'm hearing somebody else talking to you.
Sir, no one is here, sir.
Exam, you go to sit alone, man. Nobody can prompt you. Your assistants cannot come near you.
Sir.
Sir, what is hypnagogic myoclonus? You tell me. You can get myoclonus when you go to sleep or when you awake from your sleep. That is called as hypnagogic myoclonus. So involuntary movement la edume illa.
Illa, sir.
Pass pointing edume illa. Dystonia mattum irundha. Adu mattum da irundhu. Huh?
Yes, sir. Irukku, sir.
Pure cerebellar.
Yes, sir. Pure cerebellar.
You should know இது இந்த மாதிரி renal neuro syndromes எல்லாம் தெரியணும். Like adult polycystic kidney disease, nephronophthisis, von Hippel-Lippo's disease எல்லாம் தெரியணும். அப்புறம் சார் சொன்ன மாதிரி inherited ataxiaல Friedreich's ataxia சார் சொன்னாரு. அதே மாதிரி you have to think of ataxia telangiectasia. What are the other disease complex to look for in patients with ataxia telangiectasia?
So in ataxia telangiectasia, there is recurrent sinopulmonary infection will be there, sir. So the risk of skin cancer, skin malignancy, sir.
They are associated with lymphoreticular malignancy, lymphoma. They go for lymphoma, breast cancer.
Okay. Yes, sir.
So you have to look for all that. So whenever you present a complex disease, you have to see for other associated diseases. For example, Friedreich's ataxia, You have to see for diabetes mellitus, cardiomyopathy.
Yes.
அந்த மாதிரி you have to
Cardiomyopathy.
approach plus skeletal malformation. புரியுதா? Ataxia telangiectasia, you have to see for all this associated diseases.
Yes.
சரியா?
Yes, sir.
Okay.
Yes, sir.
Proceed.
Sir,
Sir, proceed, pa.
sir,
அவ்வளவுதானா?
for the investigation, sir.
You go for investigation.
Uh, Sir, actually, we have to do routine investigations like CBC, RFT, liver function test, and electrolytes. Sir. We have to treat the reversible cause of consider reversible cause of ataxia also in this case. Sir. Since vitamin E causes early onset ataxia, we have to rule out vitamin E deficiency. Sir. So we have to check vitamin E, vitamin B12 assay. Sir. Lipid profile should be done, sir, because in A beta
Sundramurthy, you are having slides, all these investigations?
Sir, no, sir. Actually, put the MRI of this patient, sir.
Okay, why put the imaging?
Sir,
கமெண்ட் சொல்வாருப்பா, நீ எம்ஆர்ஐ போடு. என்ன
So it is a marked cerebellar atrophy. Okay.
Yes, sir.
Marked. Patient is having CT scan.
Sir, no CT, sir. He is having only MRI, sir.
Only sagittal section you are having.
No, another section is happened, sir. So, the marked section.
There is molar tooth appearance like this one.
Yes, sir.
Molar tooth appearance. What condition you get about Jopper syndrome?
Jobber syndrome, there is molar tooth appearance, sir. Elongated cerebellar
You can see the pons looks like a molar tooth.
Yes, sir.
Huh?
Yes, sir.
Is there any Joppers associated with the nephrotic syndrome?
Sir,
It is one of the congenital ataxia.
It's one of the congenital ataxia presented with the hypotonia.
Hypoplasia.
Yes, sir. Hypotonia and respiratory dysfunction will be there, sir.
But it looks like a molar tooth.
Yes,
Jopper syndrome imaging.
But no other symptoms related to Jobber syndrome will be there, sir. No, there, sir. No mental.
Any other investigations?
Sir, we will do genetic study for this patient, sir.
Everything is normal.
Sir, no, sir. They haven't evaluated, sir. We called the patient for genetic study, sir. They did MRI and so they evaluated for only for nephrotic syndrome, sir. Since this is an yearly age, we have to consider the reversible causes, sir. Sir, sir, we have to consider the reversible causes of ataxia, sir. So vitamin B12 deficiency, vitamin E, hypothyroidism, and vitamin ataxia
You have
due
to
to
do thyroid profile. You have to do thyroid profile. You have to do ophthalmological examination, dilated to rule out any retinitis pigmentosa and all this thing.
Yes, sir.
Then you have to rule out investigation for ataxia telangiectasia. Okay.
Yes. Yes, sir.
Any case report of Jopper syndrome with renal dysfunction?
Sir, no, sir.
Any other congenital anomalies the patient is having?
So no other congenital anomalies were there, sir.
So the patient may have associated polycystic kidney disease, also Jopper syndrome.
Okay, sir.
So you have to rule out Jopper syndrome in this case.
Yes,
because
sir.
the MRI picture
shows molar tooth appearance.
Molar tooth appearance. Okay.
Yes, sir.
Sir, Namachivaya sir.
Yes, sir.
இந்த கேஸ் ஜாப்பர் சிண்ட்ரோமா இருக்குமான்னு பாருங்க, கொஞ்சம் எவாலுவேட் பண்ணுங்க.
So what else we should do, sir? What other investigations, sir? Sir?
Any other congenital anomaly the
அதுதான் சார் நான் கேட்கிறேன், இவன் கிட்ட காமிக்கல சார், அதனாலதான் நான் கேட்டேன் சார்.
ask them to whether it is in the ward.
இல்ல சார், they
Sir,
got
no, sir, they
discharged
got-
நினைக்கிறேன் சார். சார் ஃபோன் நம்பர் இருக்கு சார், மேபி வில் டிஸ்கஸ் இட் அகைன் சார். நீங்க எப்பவாவது நம்ம டிஸ்கஸ் பண்ணுவோம் சார்.
Okay,
ஒரு
okay.
தடவை probably we can give it for our PGs also sir.
Maybe Jopas syndrome, sir, in this case.
Okay sir, okay sir.
They maybe have associated renal anomaly like polycystic kidney.
Okay sir.
We have to roll out, sir. Nalla case, sir.
Okay sir.
Imaging la classical molar tooth appearance.
Molar tooth appearance, yes sir.
Yeah.
சீதாராமன், என்ன வேற எதுவும் சொல்றியா?
Sir, yes, sir. Sir, engages. So, sorry, without MRI, now we have to rule out treatable causes or hereditary autosomal recessive causes, sir. So, if the investigation shows any vitamin deficiency, such as vitamin E, B12 deficiency, and then in the lipid profile, if there is decreased VLDL, now the A beta lipoproteinemia will be there, sir. These are the treatable causes, sir, so that we can treat the patient with the appropriate treatment, sir. Sir.
Okay, sir. Namaskar, sir. Can we conclude?
Yes sir, we conclude sir. So hope he has presented well, sir. Sir? Sir?
Hello?
Sir?
Sir, can we conclude, sir?
We'll conclude sir, we'll conclude sir. Thank you so much sir for participating. It was nice.
Okay, so you have to little evaluate for Jopper syndrome, sir. Proper
Okay sir,
diagnosis
I'll
is
keep in
Jopper
touch
syndrome.
with you sir. I'll keep in touch with you and tell you about the progress of this
Okay,
case.
sir. Okay, okay,
Okay
sir.
sir, thank you so much sir.
Okay, sir.
Thank you so much.
Thank you, sir.
Thank you Saravanan sir.
Yeah, thank you, sir. Thank you.
Sir, next week sir, Saravanan sir.
சொல்லுங்க சார்.
Sir, next week ஒரே ஒரு பையன் மட்டும் இருக்கான் சார், கிரி வந்து.
ஓகே சார்.
கிரீன் ஒரே ஒரு பையன், அதுக்கப்புறம் all the 14 candidates are finishing sir.
பட் மொத்தம் 16 வீக்ஸ் வரும் சார். 16
அப்ப 16 weeks 14 தான்.
இல்ல சார், 2 more can represent ஒரு மொத்தம் 16 weeks presentation சார்.
So total 16
இப்போ வந்து
2 more இருக்கா சார்?
13 முடிஞ்சிருக்கு சார். 13 எவ்வளவு முடிஞ்சிருக்கு சார்?
இல்ல சார், actually there are 14 candidates sir.
ஓகே.
அதுல வந்து 13 இன்னும் ஒரே ஒரு பையன் மட்டும் கிரி வேற யார் பிரசன்ட்?
அதான் சார், 13 முடிஞ்சிருக்கு இப்போ.
ஆமா சார்.
13 candidates presented.
Okay,
we have
sir.
14 candidates but one more present. But I'm telling you about the total 16 weeks to be presenting.
Yes sir, அப்ப we'll ask, we can ask another person to repeat once or again sir.
Two more people to repeat it.
Two more people to repeat sir.
Yeah, no, 3 more weeks இருக்கு. அதுல ஒருத்தர் வந்து
Okay,
first
sir.
time.
ஆமா சார், மிச்ச ரெண்டு பேர் வந்து we can ask them to repeat sir.
Yeah, sure,
No problem,
sure.
sir.
Okay sir, okay.
Thank
you
you
sir, thank you.
Hello, sir.
Enjoy, have a great dinner and sleep.
Yes, thank you, sir.
Yeah,
Thank you so much, sir.
thank you.
Yes, sir.